general and old age psychiatry currently. So I'm doing dual training. So sometimes you get the chance to do dual training as a higher trainee, and I've chose to combine old age and general adults. So my current job in my final year is an inpatient unit, male inpatient ward in Warrington. And yeah, so yeah, schizophrenia and dementia is something that I have experience with in terms of my clinical work. So as I said, feel free to ask questions along the way. This is mainly sort of, I want it to be tailored to the to your needs as students, or what's relevant to you. So please don't be afraid to drop a message or just ask a question. It's fine. Right. So without further ado, if we get started. So these are some of the learning outcomes which we would like to focus on. So we have some structure to this presentation. So understanding the epidemiology, etiology of schizophrenia, describing the diagnostic classification, the clinical features, and the different types, subtypes of schizophrenia. Okay. So with that in mind, there are some further learning outcomes here, actually. Other causes of psychotic symptoms, because schizophrenia is not the only cause, is not the only disease which can, mental illness which can cause psychotic symptoms. There are lots of overlap with other psychiatric disorders. Comparing the different treatment options, the outcome and prognosis we'll touch on. And these are the so these are things we're going to cover: types of schizophrenia, the teams involved in treatment. So what I can tell you from my experience is how mental health teams are structured a little bit. So I'm not sure whether as fourth year students you're yet to do your psychiatric rotations and having some or you've already had some experience before, but either way, just touching on how teams are structured and geared up to treat people with mental health problems, that will be useful as well. Okay, right. So the and also what I'm going to try and do, I'm trying to tailor the presentation as much as possible. I'm not going to get too bogged down in details, but if you want to ask specific questions, please do ask. Okay, so history of schizophrenia then. So schizophrenia has been described up to 1400 BC, so in ancient literature really, and Kraepelin in 1896, he described schizophrenia as, initially it was not called schizophrenia. This was a term that came much later, so it was actually described as a dementia precox, and that's quite interesting because the fact that it was thought of as a dementia, and that already should tell you that this is there is overlap. Yeah, there is overlap. So if people who have schizophrenia, which is classified as a severe and enduring mental illness, which typically has a long chronic relapsing and remitting course, if you live long enough with it, you will get cognitive issues. Some people have it a lot sooner. Some people have the onset of cognitive issues later as it becomes more apparent, and there is usually, it affects your functioning as well. Yeah. And if you were to do neuroimaging on patients with schizophrenia, you would see subtle some neurobiological changes, and so that's why it makes sense that actually all those years ago Kraepelin actually described it as a type of dementia, but not in the conventional sense that we know it today. But this is why it's useful to think of it in that way. Eugene Bleuler came up with the term schizophrenia in 1911. So that is the history, and we all know sort of, I'm sure you've heard of Freud, who emphasized a lot of the psychological basis of the disorder as well. Okay, so the current thinking is influenced by the work of Kurt Schneider, who termed, you may have heard, Schneider's first rank symptoms of schizophrenia in about 1959. And I think at the time he thought it might be pathognomic of schizophrenia. Now, as the years have gone on and there's been more research and more experience, we know that it's not, these first rank symptoms are not just specific to schizophrenia. We can see it in other psychotic disorders and even other affective disorders or mood disorders, such as bipolar disorder, for example. So there is overlap, but back then Schneider thought that this is pathognomic first rank, the first rank symptoms. So if you had these, the thinking was then you had schizophrenia, and we'll touch on what they are. So essentially, they are auditory hallucinations, thought broadcast, thought insertion, thought withdrawal, and those terms will come up throughout this presentation. In 1970, schizophrenia was operationally defined, and as we said earlier, there are many causes of psychosis, and it's a chronic, relapsing, and remitting illness. So it's a life-changing diagnosis, and we cannot underestimate the impact on someone when you're diagnosing them with schizophrenia, not just for the for the patient, but also for their families, and it can be quite devastating. And I think it's important that we do it in clinical practice in a very sensitive way, and yeah, it's usually so the earlier what we'll talk about as this presentation progresses is what types of schizophrenia have a better prognosis, and which types of schizophrenia have a poorer prognosis. So this is using ICD-10, which is our international classification of diseases for psychiatric disorders. A new one is out, or is in the process of being rolled out. Is it ICD-11? I know that so this is what we use in Europe, and in Britain. In America, they use something called DSM, Diagnostic Systems Manuals, and they're on edition 5 at the moment. So there's some overlap, but there is some subtle differences. But we use ICD-10 for diagnosis of psychiatric disorders. So these are the symptoms, okay, these are broadly the symptoms of schizophrenia. And although so you can see at the bottom there's negative symptoms, so the top ones can be generally, you can think of them as the top 4 can be seen as positive symptoms. Okay, so positive symptoms and negative symptoms. So I mean, how I think of, so those are the symptoms of schizophrenia. You've got positive symptoms and negative symptoms. That's the easiest way to try and remember it. Symptoms of schizophrenia, positive and negative. Positive symptoms, you can think of it like you're adding something in, okay, which wasn't there. Negative symptoms is you're taking something away which should have been there or was there at some point. Okay, so positive symptoms are usually delusions, hallucinations. So delusions are unshakable, fixed, false beliefs, and hallucinations are experiencing a perception via a stimulus, which is not there in the absence of a stimulus. Sorry, so the perception of a stimulus in the perception without an objective stimulus. Okay, and that differs from an illusion. An illusion is more of a misinterpretation. So, for example, if I was staring at a wall and I saw a guitar, that would be a visual hallucination, yeah, because there's no stimulus to suggest there is a guitar there. However, if I was looking at a tree and I mistook that for a guitar or a person, that could be classified as illusion. Okay, then so those are the main 2 positive symptoms. Then you have thought disorder. Okay, thought disorder, the best, so disorganized thought processes, thought insertions, thought withdrawal. So what is thought disorder? It's a disorganized thought process. And how do we clinically, how do we see that in clinical? How does that manifest in clinical practice? Well, if you're talking to a patient and you're struggling to follow them, or their thoughts appear disjointed, the content of their speech is disjointed, you can't quite follow what they're saying, maybe they jump from one topic to another and it's just disjointed, then you can suspect strongly that there is thought disorder there. Okay, Catatonia. So this is a motor manifestation of a psychiatric underlying psychiatric problem. Okay, so it's not just confined to schizophrenia. It's not just you see in a schizophrenia. You can see it in other psychiatric problems like depression, for example. So catatonia, you can think of it like an umbrella term. Okay, any motor manifestation of a psychiatric illness. Stupor is something we see rarely, but I've seen it where patients become motionless, and this is often, it can be a psychiatric emergency. It can lead to it because patients often stop eating, stop drinking, and they're often hospitalized, and they require quite assertive, close nursing care in an inpatient unit. And usually, I mean, I personally have had patients present with in this way, but motionless, not eating and drinking, gradually over a period of a few weeks, with an underlying diagnosis of schizophrenia. And the treatment essentially is starting with benzodiazepine, some lorazepam, and usually the transformation is in the majority of cases is quite dramatic. Yeah, within a day, within 6 hours, you see a marked change. If they don't respond to that, then ECT is probably the next line in treatment. So this is something which you can see a dramatic response to treatments in an inpatient setting usually, because I don't think you'd want to be treating someone with catatonia on a in the community. So it's not just stupor. There are some others which we won't talk too much about, but there is things like terms like waxy flexibility. There is posturing. There is abnormal movements, which all come under the umbrella of a catatonia, and you can see them more suggestive of schizophrenia. But in stupor, you can see that in depression as well. Negative symptoms now. So negative symptoms is a way of taking something away. Okay. So things like poverty of speech. Yeah. So poverty of speech and thought, becoming apathetic, anhedonia, where you're losing interest in things that you previously used to enjoy, reduction of social drive, loss of motivation to do things, inattention to social or cognitive input, and just a general malaise and a lack of initiative and drive. And this is negative symptoms of schizophrenia is often very difficult to distinguish between schizophrenia or depression. So is it negative symptoms of schizophrenia, or is it depression, or is it something else? Is it a prolonged grief reaction after a significant life event like a bereavement? There is a lot of overlap, and usually, often it's maybe missed initially, and maybe you've tried to treat with depression antidepressants, but there's been not an expected a response to treatment, and then either other symptoms emerge, or you start to suspect that it might be maybe because there's family history of schizophrenia, or there's the behaviors after a period of assessment on inpatient will suggest that actually this may be negative symptoms of schizophrenia. And typically, in terms of prognosis, positive symptoms have a better prognosis because they're more amenable or more responsive usually to treatment, okay, than negative symptoms. And why is it important to distinguish between the two? A, prognosis, like I've just mentioned, and also we can tailor our treatment because there are some choice of drugs, so antipsychotics, which have a bit more evidence in negative symptoms. And so that's why it's important to distinguish that. We talked a little bit about what delusions are. We mentioned fixed false beliefs. Most delusions tend to have a persecutory theme. The majority that I've had experienced in my clinical experience tends to be persecutory type delusions. And there's many theories, psychological theories of why this might be, and whether hundreds of years ago it would have been the same or not. Essentially, we all have a fight or flight response, and we all have a survival instinct, and persecution, you know, having a level of skepticism has helped us survive throughout the evolution of humankind. But when it goes, when when it can get out of control, and you know, it starts to become, those areas in the brain start to be activated when they shouldn't be activated, those warning systems in the brain, and you can start to see how someone starts to feel persecuted persistently. And so that may be the basis of why persecutory delusions is the majority of delusional type manner of thinking we see in psychiatry. So it's defined as a fixed false belief, but it can't be in keeping with the patient's social, cultural, and educational background. And that's very, very important, because you know, psychiatry, as any health specialist, is multicultural, and we do see patients with different cultural backgrounds. And you know, just because someone is saying something, maybe talking about witchcraft or genies or things or voodoo, does not mean that that is actually, you know, delusional. And it's important to take a step back and consider their culture as well, because it might be it might not be delusional. It might be in keeping with their cultural beliefs. So thought insertion. So we've mentioned this term, but what is it actually? So it's where someone is having thought processes, but they feel that someone or something is inserting thoughts into their head which are not necessarily their own. Okay, it's an external agency which is putting thoughts into their head. And in this, extraction is the same. They feel something external is taking thoughts out of their head. And broadcast is like they think their thoughts are being broadcast so that they think that others can read their mind. And this is important, because it can often, when you're assessing risk in psychiatry, it can often influence the risk management. So if someone is it's linked often with delusions of control. So if someone feels that they're not in control of their actions and behaviors, because they feel that something external is putting thoughts into their head, and that thought is telling them to do something, then that comes under the realms of this, how it links in with control, and that's why it's important to tease it out in the psychiatric assessment. So delusions of control, we've touched on that. Okay, so patients may feel they're not in control of their actions, that someone or something is telling them to do something, whether it's through thought or whether it's through hallucinatory type symptoms, so auditory hallucinations, to what we call command hallucinations. So command auditory hallucinations is where people hear voices telling them to do something, whether it's to harm themselves, it could be harming other people, or harming someone specific. And you can see how it's important to sensitively tease that out and during a psychiatric assessment. And that's why in psychiatry it's so important. And you know, however experienced you get, it's always, the biggest challenge is establishing that rapport with patients who are acutely unwell, having that therapeutic rapport, so that they can feel, you can build up that trust in that assessment setting, so that they can start to feel like they can trust you despite not trusting maybe the world around them, and start to tell you a little bit about their experiences, so that you can sensitively assess that risk. And that comes with experience. And yeah, it takes a lot of time, and I mean, I'm still learning, you know. Sometimes it's not possible to patients are just too disturbed, and you have to accept that actually we're not going to get that information now, and we just need a period of further assessment, and they might need some medication first, or some period of low stimulus environment, nursing on the ward in a quiet environment, before we can revisit and try and assess the risk again. Okay. Delusions of reference. So referential delusions are when people feel that they're being talked about. Okay, and it's a delusion. It's of delusional intensity when it's unshakable. They feel that other people are talking about them being nasty, or you know, they're being referenced maybe on television adverts, or you know, so or on the radio. So this kind of people are making reference to them, okay, about them, and usually it's with a derogatory way, and it may have some greater meaning for the patient, okay, which will need to be explored. So it doesn't have to necessarily be of delusional intensity. So all of these things we've talked about, all of these symptoms so far, they're on a spectrum. So it's to having no symptoms to having it of delusional intensity. And in the middle, it can often be something called ideas or overvalued ideas. Okay, so that's when you think that, you know, people are talking about you, or maybe there's an advert which is has some meaning towards, special meaning towards you, but you're not sure, and you're not, certainly you may be amenable to, actually maybe it's not true, you may be amenable to evidence from other people that actually maybe it's your mind playing tricks on you. But that's often the stage where we need to try and treat these people, because if you leave it untreated, it can often escalate to a full-blown delusional intensity, and then it can increase risk. Okay. Right, so just keeping an eye on time. Okay, so we're near the halfway point. Do we have any questions at this point? Because I mean, a lot of the questions may be covered in as I'm going along, but I know I'm conscious. I just want to check in now and again. Has anyone got any questions so far? Anything they don't understand, or should we continue?
I think there's a question there in the chat. Dr. Singh,
okay,
can you see that there?
Look. Let me have a look. Sorry. Let me get this up. Oh, yes, I can see. Sorry. Yes. Okay. So when would a separate diagnosis of depression be made in presence of negative symptoms? Good question. It's difficult. It's difficult. In psychiatry, you need to be comfortable with uncertainty and, you know, accepting that you might need a third assessment. Sometimes it can be very difficult. And what's to say that someone doesn't have negative symptoms of schizophrenia and also comorbid depression? You know, you know, they could have both. It's what's key here is the history, and taking everything account. So corroborative history is often important. When did the symptoms start? Is this an extension of symptoms that have been going on for years, or is this more of a recent deterioration? Because as you know, with depression, there is specific criteria. So it's usually 2 weeks of depressive symptoms. So low mood, not eating, not drinking, low energy, poor, low motivation, maybe suicidal thoughts, negative cognitions, so hopelessness, helplessness, worthlessness. So from the history, if those depressive symptoms have seemed to emerge with a within the recent past, then you would suspect maybe this is depression on top of something else maybe going on. Or if it's clear that there's no hint of schizophrenia, it's just depression, then that's easy. But if someone has a diagnosis of schizophrenia and is predisposed, we know they have negative symptoms, and then they become depressed, usually you would see that actually the baseline with negative symptoms is they have poor self-care. They require a lot of prompting for medication, for getting up in the morning and doing things. But all of a sudden, within a space of a few weeks, that baseline has changed. Now they're staying in bed all day. They're no longer amenable to prompting. They're no longer for getting up or having prompting for medication. So that would represent a change from a baseline, and then you would start to suspect, okay, something else going on. You wouldn't rule out that perhaps it is maybe a relapse of their schizophrenia if they're not taking their medication or some other reason. But you would also have a low threshold to consider a comorbid depression. And often it's very difficult to distinguish because there's no test that you can do. There's no blood test. There's no one neuroimaging that you can do to diagnose it. So often you have to trial by trying to treat. Okay, so you would try to treat the depression, and if there's no response, then you would keep your mind open. So I hope that has helped in answering the question. Essentially, there is no easy answer, and there is no one test that you can do to try and differentiate. It's clinical, and it's from the history, and it's from your assessment. Next question is, was catatonia a negative symptom? That's a good question. I don't think it is. It's a motor manifestation, okay, of a psychiatric illness, okay, because catatonia, you can have not just stupor where you're just immobile and not moving, but you can also have excitability, hyperactivity. So I wouldn't necessarily say it's a negative symptom, because actually, if you think about it, if negative symptoms are taking something away from you, catatonia was never really there. So catatonia is usually added in. So if anything, it would be better categorized as a positive symptom, although I don't think it typically is. But it'd be better seen as termed as a catatonic, as a positive symptom rather than a negative symptom. Okay, is thought disorders, next question, thought insertion withdrawal, but manifest clinic as nights move thinking, flight of ideas? Yeah, it's all similar. Yeah, exactly. So thanks, Zoe, for that question. So essentially, in the things the chat you've described there, how those patients are going to, when they start talking to you, whether they have nights move thinking, flights of ideas, thought insertion with withdrawal, when they're talking to you, they can often, it's difficult to follow them. Okay. How do you tease out thought insertion withdrawal? Sometimes it can be difficult without actually asking the patient and them telling you. Okay. Flight of ideas is again, is not just confined to schizophrenia. It can be, it's when patients are getting a lot of ideas in their head. Okay. And it can often be a sign of maybe a mood disorder, so maybe bipolar disorder, a manic relapse, etc. So thought disorder, just think of it, if you're talking to someone and they're not making sense, then you suspect a thought disorder. With further questioning, you can try and then think about, okay, well, what type? You can think to yourself, what type of thought disorder am I seeing? So there's something called loosening of association. So the patients may be talking to you and they're moving from topic to topic. It appears disjointed, but then when you reflect on it, there's a loose link between what they're talking. Sometimes it's no link. They can be talking about their picnic with their friends one day, and then I don't know, a TV program the next, and all of a sudden they're talking about a persecutory belief they had. So they're making no sense whatsoever. Okay, that is obvious thought disorder. Sorry, Zoe. I hope that you're a little bit clearer in at least being able to recognise a thought disorder when you see it. Okay, on the wards. Then you have. Yeah, thanks. It is absolutely, comorbidity is definitely a complex issue in psychiatry. And I think psychiatry, there was a period of time where some psychiatrists would think that actually you can only have one thing wrong with you in your brain and we treat you for that. And you can't have comorbidity, so you can't have maybe a bipolar disorder or schizophrenia. And then things change. Sometimes, I think that from my experience, the thinking now is you can have comorbidity. Yeah. But I will leave that to for other presentations, because I know you've got other topics today about mood disorders and things. So back to the presentation. I will just share my screen again from current slide. Okay. So we talked about what hallucination is. Running commentary. What's running commentary? So running commentary is where patients get an experience where all their activities, whatever they're doing, is being commented on. Okay, by a voice. So think of it like, to them, they experience it like their life is being commented on, like a football commentator commentates on a football match in the same way they would experience their life being commented on. And you can imagine it's quite distressing. Third person hallucination. So again, this is more typically seen in schizophrenia. Third person is where so if I was getting the symptoms of third personality hallucinations, I would be experiencing voices referring to me in the third person, so not talking directly to me. So it's not like second person where you're this, you're rubbish, you're this, you're worthless, you know, not that. So it's third person, is it can be off multiple voices talking amongst themselves about you. So you know, that Krishna Singh, he's an awful chap. He is. He's got, you know, he's got nothing going for him. He should just, you know, I don't know why he bothers with life. That sort of thing. That is third person, because the voices are talking amongst themselves about me. You can often get, well, when I say often, it's not usual, actually, coming from some part of the body. So it doesn't necessarily mean that, you know, it's coming from outside your head or inside your head, the voices, or voices, or any hallucinations. Okay, so hallucinations can't, you know, don't have to just be auditory, do they? They can be in any of your senses. So they can be taste, they can be smell, they can be sensory, yeah, especially sensory hallucinations. We see are delusions of touch, etc. Patients with trauma history, especially with history of sexual abuse, they can get real sensations in certain parts of their body, which would be very distressing for them. And I think of it like, how many times have you you've had your, I think we've all experienced it, probably, maybe. How many times have you had your phone in your pocket and you think that it's vibrated, but actually when you check it, it's not. You know, so that's how it can come across to patients. So so yeah, I mean, I'm just trying to normalize it. You know, it's not. It's something that it's not uncommon. You know, I think we've all had that experience a little bit. Somatic hallucinations is again related with body parts. It could be it could be to do with, you know, any body part. Yeah. I've not really seen somatic hallucinations. I've seen hallucinations mainly. So auditory are the main. Visual you see in you don't really see in schizophrenia. You see mainly in delirium, or you see in certain dementias. But I haven't seen it in schizophrenia. Um, Another one is actually people who um, experience sort of like bugs running under the skin and things. It can often be due to drugs, cocaine, etc. Interestingly, cocaine increases dopamine in your brain, and that's the main sort of widely accepted hypothesis. Although there are others, but a widely accepted hypothesis is that dopaminergic hypothesis of schizophrenia as a cause. Although the causes are usually genetic and environmental. Because I know this slide, this presentation doesn't really touch on causes, but whilst we're talking about it, we can just touch on it. So causes are, you can see it as genes or environment, okay, or it can be a combination, okay, and how the genes interact with the environment and the other factors, the biopsychosocial factors. So the social factors. These patients are more vulnerable to becoming unwell because of that genetic hereditary of, maybe they have a family, first degree family member with a psychiatric disorder, schizophrenia, or a psychotic disorder. So genes and environment, and the most commonly accepted hypothesis for from a neurochemical basis is a biological basis, is dopaminergic overactivity. So that's where excess dopamine. That's why if you taking dopaminergic drugs like cocaine, amphetamines, can give you psychotic symptoms like hallucinations and delusions. And what else? So yeah. So it can also give you these sensations under your skin, bugs running, and that can be because of dopaminergic excess. How do we know this? Because antipsychotic drugs are dopamine antagonists, so they work to oppose the action of excess dopamine. So that's where the hypothesis has come, and that's why positive symptoms are better, or have a better prognosis than negative symptoms. Okay, because positive symptoms have more evidence that they are due to excess dopamine, and hence they're more amenable to treatment, more responsive rather to treatment with antipsychotic medications. Thought disorder. We've talked about a little bit about loosening of associations, and we have also talked about how you can recognize it from speech and also writing. So patients often struggle to verbalize themselves, and they write. They just put all their thoughts down on paper and they hand it to us in ward reviews, and then you can see when you're reading it, it's difficult to follow. It's muddled, it's illogical. There's no object evidence if it's a delusional content. And this is a good way to think about it. The more you attempt to clarify, the less you understand. So as you try to explore with the patient how they've come to that thought or how they've come to the evidence, that delusion, it just doesn't make sense. And that's thought disorder, because you can get delusions in the absence of thought disorder, and patients who you can clearly, they've got a well constructed, systematized, complex delusional system, and it all makes sense to you as they're explaining it. Okay, but then they've just got the delusion, they've not got any thought disorder. And that can be seen in something called delusional disorder or persistent delusional disorder, which is often a differential diagnosis in patients with who you suspect have a schizophrenia or a psychotic disorder. Typically, from my clinical experience, the difference between schizophrenia patients and delusional disorder is that you tend to get schizophrenia patients coming in more in contact with mental health services. Why? Because it tends to affect their functioning more and distress more, whereas delusional disorder is typically they manage to function despite having this delusion. They manage to function in the community, in their lives until it reaches a tipping point, and that tipping point can come because of external factors like excess stress in their lives. They may have had job loss or bereavement or something, or something might happen, and then there's more stress, and then the delusional systems take over their lives, and then they clearly can't function anymore. Catatonic behaviour, we touched on it, didn't we? So these are the different types of catatonic behaviour. Excitement, is the complete opposite of stupor, like we've said. Okay, posturing is where patients just, they might come into clinic and they might have one arm in the air and one leg up in the air, and there's no real explanation as to why that is. This is all under the umbrella term of catatonia, by the way. All these excitement, posturing, waxy flexibility, it's all catatonia is umbrella term. Waxy flexibility. So if someone comes into your clinic and they come in like this with their arm up, okay, and if you try and then touch their arm and then move it down, okay, you move it down, and then they adopt this new position, and then they're staying in that fixed position, and then you put their arm next to their waist, and then they hold that position. So whatever position you move their limb or any part of their body, they will just continue with that. That's waxy flexibility, almost like putty or gel. Putty, you mold it and it stays in that position. Negativism, I think, is again, I've never seen this, by the way, in clinical practice. Some of my colleagues, who are giving you a talk, they may have seen it. Negativism is where, for example, if someone's got their arm up in the air and I try and press down to just basically return it to their waist, they oppose me with the same force, the proportional force, so that they keep that position. Their arm is still in the air. They keep that position. I'm trying to return it to a normal position next to their waist, but they won't lie. They'll just oppose pressure. It's almost like asking someone to do a neurological examination and asking you to oppose them with proportional force to show that they've got, power in their limbs. Negative symptoms we've talked about. Blunting of emotional response. So what does that mean? So we all have a range, don't we, of how we respond to the environment. So when someone tells a joke, we laugh. When we express it by laughing. When someone is depressed, we express it by mirroring them, by or if I'm depressed, I'm going to be I'm going to be blunted. I'm not really going to be that bothered. I'm going to be isolating myself. My facial expression is going to be blunted. I'm not going to be expressing necessarily happiness, for example. I'm happy when someone tells a joke by smiling. I'm just going to be indifferent to it. Or it's a spectrum, you see. So it can be blunting means it's usually you might see some creases in the cheeks, a little bit of smiling, but it's certainly not proportional. Okay, so that's a blunting of emotion response, where someone is smiling a little bit, but not as much as you'd expect. Yeah, that's just one example. Paucity of speech, lack of spontaneity of speech, basically. Not, you can't really engage them in a conversation. Often they're just one or two word answers to your questions, and they're just apathetic. They don't have the volition to get up and do things. And again, be sure it's not depression. And like the question was earlier, we talked about how best to differentiate that, and sometimes how to accept that actually you can't at this moment in time, and it's just going to have to be revisited. You're just going to have to keep assessing it longitudinally whilst keeping them safe. Different types of schizophrenia. Most common is paranoid schizophrenia, and we touched, didn't we, about how paranoid thoughts are we tried to explain why paranoid thoughts might be more prevalent in society, because it's served its purpose historically to keep us alive. And now that's why paranoid delusions are the most common types of delusions, and paranoid schizophrenia. So paranoid schizophrenia is a preoccupation when someone's preoccupied with delusions, hallucinations. Usually it's persecutory content. This is typical more of paranoid schizophrenia, I think. So rather than me going on and talking about each subtype here, we will read Dr. Simon's description here. So well-organized paranoid schizophrenia, well-organized delusions, hallucinations, thought process and mood relatively spared, right? So they typically, often these patients don't necessarily exhibit thought disorder. So they can often you can elicit the delusions with exploration, and they make sense. It's not like they're struggling to follow them through their speech. They can describe their delusional system and hallucinations. It has more of a genetic content. It's a more genetic basis rather, and it's a later, more acute onset. Don't know what that means actually. Whether it means that the later in life it happens, the more acute onset. Generally, think about it as a preoccupation with delusions, hallucinations, with no real evidence of any thought disorder is not a prominent part of the clinical picture here. Okay, and the mood is relatively spared. Hebephrenic schizophrenia, again, so paranoid is the most common type. These are more uncommon types. So hebephrenic schizophrenia is characterized by almost like childlike type behavior. Behavioral disturbance is more of a prominent part of the picture here. Mood is inappropriate, and by inappropriate, it can be what we term incongruent. Incongruent. So, for example, if a conversation is happening about someone being, I don't know, someone has died recently, and so you are responding inappropriately to that. So you're maybe smiling about it, or that is incongruent mood. So you see this in this type of schizophrenia, but this is not isolated to just this type of schizophrenia. You do see it in some other psychiatric disorders. Thought disorder is prominent here compared to paranoid schizophrenia, and delusions are not highly organized, again because of the thought disorder, probably because actually when you're talking to them, it's just difficult to follow sometimes, and hallucinations are not elaborate. So already you can see there's no diagnostic test that you can do to differentiate the subtypes. It's history, it's a clinical history, and it's reading through the notes, and it's a clinical diagnosis. Catatonic schizophrenia, we said it's a motor manifestation of a psychiatric. Catatonia is a motor manifestation of a psychiatric disorder, and catatonic schizophrenia is where motor symptoms are the predominant psychiatric disturbance. Okay, change in activity, delusions and hallucinations are less obvious. Okay, and that's will be obvious in the clinical history. Okay, simple schizophrenia is I have not seen it. Someone termed as simple schizophrenia, but this is where negative symptoms are the predominant feature. Okay, so it's insidious development of odd behavior, social withdrawal, declining performance at work. Clear schizophrenic symptoms are absent, so your delusions, your hallucinations, your thought disorder are typically absent, and it's difficult to identify reliably. And hence, my opinion is, is this a diagnosis of exclusion? Okay, so you need to exclude. You don't. This is not the first thing you should think about. This you should think about the more common causes first and work your way down. And this is diagnosis of exclusion, like a lot of medical conditions. Yeah. Epidemiology of schizophrenia, right? We have 1% of the population. Okay, is the prevalence. Similar rates in all countries between the sexes, and men have an earlier onset typically. Outcome and prognosis. Outcome is better in the developing world. That's interesting, isn't it? And men are more likely to develop enduring negative symptoms. 20% have a complete recovery, 20% remain symptomatic, 60% have a fluctuating course of it. I sometimes think if you're going to think about psychiatry and think about there's something called the rule of thirds, which I find helpful for me to think about. Generally, so about a third of patients will respond well, a third of patients will respond partially, and a third of patients will not really respond and have more treatment resistance. And this is just a way of framing it in my brain that I find that the whole of psychiatry really, each disorder is going to have its own rates of, and it's going to fluctuate around that. But generally the rule of thirds helps me to frame my thinking. In the USA, it's 2% of the gross GDP, the financial cost of it. So you can see why it's important with regards to the cost, because obviously if patients are not functioning, they are, they're reliant on the state rather than working. Okay, so it's this is why treatment is so important. I'll just at this point, okay. What I will do is I will just run through these slides because I'm aware of we're running up to 8 minutes, okay? And then I'll just get back, and the last thing I'll do is answer the questions. So any more questions, please put them in, okay? And I'll do my best to answer them. We touched on etiology, haven't we? We have genetic factors. You can see here, there is clearly a genetic basis. Monozygote twins have a 45% concordance. And we've talked about the interplay between genes and the environment. Okay, so the environment is very important. Okay, not necessarily you'll develop schizophrenia just because you have genetic predisposition. Non-genetic risk factors, yeah, right. So what it's found that mothers who have obstetric complications are more likely to, so you're more likely to get schizophrenia if you were born and your mother had some obstetric complications. Okay, and winter birth has been linked little bit to it as well. Illicit drug use, cannabis use, other illicit drugs, can be a risk factor. Brain damage, infection in childhood, or maternal infection. So generally obstetric complications can be a risk factor. So if you're planning a baby, to try and plan to have it in spring and summer. New developments in understanding brain activity in schizophrenia, functional brain scanning. Again, we touched on this, didn't we? That actually, if you think about the history and why it was termed dementia precox, if you scanned everyone with schizophrenia with functional brain scanning, and then you did the same with patients with dementia or early stages of Alzheimer's disease or any other type of dementia, you'd see changes which would explain their clinical manifestation. Okay, you'd see some overlap there. So reduced activity in frontal cortex is seen in negative symptoms. Okay, and that makes sense because your frontal lobe is it's where the executive functioning and the planning, the being organizing, the motivation, all those, it's where it's regulated. Okay, without going into much more detail about that. So if that area becomes diseased, whether it's because of a dementia disease or whether it's because of a schizophrenia, that's why you get the symptoms. And also in depression, You get reduced activity in your frontal cortex if you scan them, which would explain that as well. Over time, especially people with a chronic history of depression, if you scan them, you would probably see some reduced activity in frontal cortex as well. Auditory hallucinations, increase in activity in speech area and failure of inhibition of auditory area. Hence, that makes sense, doesn't it? Why they get those auditory hallucinations. We use a biopsychosocial approach. It's very important, okay, to take everything into consideration. So there's no point treating someone with drugs to get them better on an inpatient ward, but then you're sending them home to an environment where there's a lot of stress, and you're just sending them into the same social circumstances, which are clearly going to cause a lot of stress. Okay, maybe they've lost their home, or the whatever the social circumstances, you need to address everything. And that's why we work in multidisciplinary teams on the ward or in the community. Yeah, OTs, social workers, psychiatric nurses, psychiatrists, psychologists. We all work together to address each of these. Okay, right, different teams. So this is, you can see, I'm not going to dwell too much on this, but this is how often referral comes, or how patients come into contact with our services, GPs, or in emergencies through A&E or police. And then, yeah, biological treatments, antipsychotics we've talked about generally, and the dopamine hypothesis we've talked about. You can give oral IM. We restrict IM to only in emergencies, or if patients have for tranquilization, but also if patients have poor compliance with oral medication. Yeah. Antidepressants, antipsychotics. Okay. So 6 weeks is typical. We treat them at an adequate dose for an adequate duration, typically about 6 weeks. If they fail to respond to 2 courses of antipsychotics, sorry, 2 different antipsychotics for an adequate course and an adequate dose, they're technically defined as treatment resistant. And the best antipsychotic for treatment resistant schizophrenia is clozapine, but it requires close monitoring, so you can't give it to everyone. So the patient has got to be amenable to having blood tests weekly for the first, weekly for a period of time, and then it goes to fortnightly, and then eventually it's less frequent. But unless they're going to engage with that blood test, they're not really a candidate for it. Why? Because of the risk of neutropenia. Okay, and obviously infections as a risk of that. Treatment resistance, we talked about that. Urine drug screens commonly done first thing when patients come on the ward. Benzos, antidepressants, post-schizophrenia depression. Let me just quickly touch on this before we answer some final questions before we finish. So I've had some experience of forensic psychiatry, and when I was working forensic services, so you'd have patients who, for example, who were detained in Ashworth Hospital, and they during a psychotic episode, they had committed a quite a disturbing, really horrendous crime. Basically, maybe family members were killed or something, and they were responsible. When they came into hospital, they were treated for their disorder by antipsychotics. The psychotic episode got better, and then they realized what they did, and understandably depression set in. So that's an example of post-schizophrenic depression. So you treat the schizophrenia, and then often they need, the depression sets in. In a secure setting, it's easier to manage than if someone is developing post-schizophrenic depression in the community. Okay, where supervision is you can't supervise everyone 24/7 in the community. So that's an example of post-schizophrenic depression. And there's 50% patients attempt suicide, and it's not just because they've done something in forensic setting. It could be because their symptoms are just so distressing, and it doesn't mean that it's just post-schizophrenic. It could be alongside the schizophrenia. They're so distressed by their symptoms, the hallucinations tell them to do things that they just they just feel like life isn't worth living. And unfortunately, there is a 50% patients attempt suicide. So having schizophrenia is a suicide risk. Psychological treatments, we won't touch on that too much, but we worked alongside psychologists. CBT, okay, cognitive behavioral therapy. So how your thoughts affect your feelings and how your feelings then affect how you behave. Yeah, that model used to try and work with patients, and it's recommended by NICE. These are the social treatments. So this is basically expressing relapse rates. So the highest relapse rates are patients who don't receive medication and have high expressed emotion. Okay. Holistic management. Okay, that is the key. If you're going to take anything away from this, schizophrenia it's a chronic illness. It's actually a devastating illness, right? To diagnose someone, please do not underestimate it. Most patients with schizophrenia are not dangerous, despite the misconceptions. Okay, they're most likely to be dangerous to themselves, okay, than other people, despite what the media report. And yeah, I'm happy to share the slides. And let me just look at some questions which have come. Okay, right. What is the difference between tangentiality and loosening of associations? Right, loosening associations, tangentiality. Right, good question. Tangentiality is when they go off on a tangent and never come back, and you have to redirect them. Okay, which is different from circumstantiality, because circumstantiality is they eventually come round. Loosening of associations means that there is a link between between what they're saying, yeah, but they can still go off on a tangent. So in a way, you know, they are. You can have tangentiality without having loosening of associations, but they can be linked as well. Yeah, they can. So that there is a, I can't say they're exactly the same thing, but often you see them together. So what is this between schizophrenia, schizoaffective disorder, schizotypal? Okay, right. So schizoaffective disorder is when you have schizophrenic type symptoms and mood symptoms together in the same episode. So someone who is presenting with schizophrenic symptoms like delusions, but also there is a mood element to it. They appear to be elated as well while they're saying it. Their speech is pressured. They've got a lot of energy, not sleeping. So then you would suspect, if they're having them both together, these delusions and these symptoms, that maybe they're having a schizoaffective episode, which means that they've got symptoms of both, a mood disorder and schizophrenia. In the case I've just described, they've probably got a manic relapse of schizoaffective disorder. You can have a depressive relapse of schizoaffective disorder. Schizotypal personality disorders are different. Okay, just think of that as a different thing. Okay, and usually this is a diagnosis of exclusion, and it's very hard to do that, to diagnose a personality disorder, unless you've got corroborative history. Personality is enduring. Okay, it's pervasive and it's enduring, so it's throughout their life. Okay, and usually it causes difficulties to them and others. Schizotypal typically don't really come into contact with mental health services, or schizoid personality. Schizoid are odd, eccentric type. Okay, have a read about what cluster A, cluster B, and cluster C personality types are, and think about which ones are most likely. Yeah, cluster A, you have odd, eccentric. Cluster B, you have your histrionic. You have your dramatic. So the cluster B is more likely to come into contact with mental health services. Cluster C is avoidant, anxious, dependent, right? So again, they are less likely than cluster B to come into contact with mental health services. But essentially, personality disorders are diagnoses of usually exclusion, and you need good corroborative history for that. And the next one is simple schizophrenia even schizophrenia if simple schizophrenia even schizophrenia if there is clear characteristic symptoms or absence? Is the pathophysiology thought to be the same? It's a diagnosis of exclusion. Okay, pathophysiology. Actually, you know, the cause of schizophrenia is actually unknown. Yeah, to be politically correct here, it's actually unknown, but there's lots of theories. Okay, so there's no specific pathophysiological change that you can look under, take a sample from a brain biopsy and look under a microscope and say that's pathognomic of schizophrenia. It's not like that at all. It's actually unknown is the cause, but there's a lot of theories. Okay, and simple schizophrenia, as I said, it's a diagnosis of exclusion. Difference between posturing and waxy flexibility. Waxy flexibility is when you can mold them into like a putty. So if their arm is above their head, you can grab their arm and gently move it to all the way down next to their hips, and they'll stay there. Posturing, I think, is when it's more difficult to do that. They won't really they're not really moldable. Okay. Uh,